Laparoscopy-assisted versus balloon enteroscopy-assisted ERCP after Roux-en-Y gastric bypass. Introduction. Obesity is a global challenge with a threefold increase in prevalence since 1975. Bariatric surgery is the most effective method for sustained weight loss for obese patients who fail conventional lifestyle intervention therapy. Roux-en-Y gastric bypass, RYGB, has been one of the most commonly performed bariatric procedures. Patients with a body mass index, BMI, of more than 40 kilograms per meter squared have an 8-fold increased risk of cholelithiasis compared with patients with a lower BMI. The risk for cholelithiasis is further increased after RYGB, which may be due to increased bile cholesterol saturation during rapid weight loss and gallbladder hypomotility owing to the duodenal bypass. Endoscopic retrograde cholangiopancreatography, ERCP, in patients with altered anatomy due to RYGB is technically challenging owing to the long intestinal access route to the major papilla, which cannot be reached by a conventional duodenoscope. The most common interventional strategies for this patient group are laparoscopy-assisted ERCP, LA-ERCP, and balloon enteroscopy-assisted ERCP, BEA-ERCP. LA-ERCP has the advantage that no specific training or instruments are needed, and cholecystectomy can be performed concomitantly. However, it requires that both an ERCP and gastrointestinal laparoscopy team collaborate on the procedure. BEA-ERCP, on the other hand, requires specialized endoscopic training and instruments, but only a single endoscopy team, is less invasive, and can be performed in an endoscopy room as opposed to an operating theater. In 2007, Tønnesen et al. Described the first cases of BEA-ERCP in the journal Endoscopy. Since then, clinical experience with LA and BEA-ERCP for RYGB has been documented in several case series and systematic reviews, but few studies have compared the two methods. The largest comparative study to date included 72 patients, but gastrostomy was performed both by open and laparoscopic surgery in this study, and in most cases the gastrostomy was allowed to mature for 4 to 6 weeks. The purpose of this study was to expand the knowledge of how LA and BEA-ERCP compare in terms of their performance, benefits, and harms for post-RYGB patients. For this purpose, the authors compared the two methods at 2 tertiary care endoscopy centers. Background. Patients who have undergone RYGB are at increased risk of biliary disease necessitating ERCP. The most widely used approaches to perform ERCP after RYGB are laparoscopy-assisted ERCP, LA-ERCP, and balloon enteroscopy-assisted ERCP, BEA-ERCP. There are few studies comparing these procedures. The authors aim to compare the performance, benefits, and harms of LA-ERCP and BEA-ERCP in RYGB patients. Methods. Tønnesen et al. Identified all RYGB patients who underwent ERCP at 2 tertiary care endoscopy centers in Oslo, Norway, between May 2013 and December 2017. One center performed BEA-ERCP, the other LA-ERCP. Procedure success was defined as fulfillment of the therapeutic or diagnostic aim according to the procedure description. Adverse events were classified according to the Clavian-Dindo grading system. Results. During the study period, 40 BEA-ERCP and 39 LA-ERCP procedures were performed in 68 patients. Procedure success rate was 72.5% for BEA-ERCP and 87.2% for LA-ERCP, p equals 0.14. Adverse events occurred in 18% of BEA-ERCP and 28% of LA-ERCP, p equals 0.23. Serious adverse events, Clavian-Dindo grade greater than or equal to 3B, occurred in 2.5% of BEA-ERCP and 7.7% of LA-ERCP procedures, p equals 0.36. Concomitant cholecystectomy was performed in 25 of the 39 LA-ERCP procedures. The median procedure times for LA-ERCP performed with and without concomitant cholecystectomy were 201 minutes and 140 minutes respectively, and for BEA-ERCP was 125 minutes. Conclusions. In experienced hands, both LA-ERCP and BEA-ERCP have high success rates after RYGB. The choice of approach should be individualized according to patient characteristics and available physician competence.